Paul, thank you for accepting my invitation.
Thank you for having me. Nice to meet you, Rod.
Um, Paul, knowing, can you tell us a bit about yourself? What is your formation and where do you work right now?
Yeah, I'm an associate professor at McMaster University in the Department of Psychology, Neuroscience, and Behavior. Um, my my background is kind of a strange academic mixture. I started off in aerospace engineering. I got my bachelor's in that. Then I went and got a law degree, and finally, I went and got a degree in behavioral ecology, which is an evolutionarily informed approach to understanding behavior in um, animals, non-human animals. But I did it explicitly with the intention of I wanted to learn about the principles of evolution so that I could apply it to understanding human psychology and human behavior. Um, and so after I got my PhD in that, I then did uh, some years as a postdoc in an institute for psychiatric genetics in Richmond, Virginia. Um, and from there on, I got my position here at McMaster. So my focus is on understanding the evolution of depression. I do a bit on suicide as well. Um, and yeah, I mean that's the general, just sort of brief background.
So can you tell us also a little bit about what is evolutionary psychology? I know it's a complex answer, but because
Yeah,
so most of my listeners are prescribers,
sure.
and our psychological basis in our training is not that strong.
Yeah. Okay. So evolutionary psychology is, I mean, there different people will give you different answers. I like to think of it as the application of evolutionary theory or an evolutionary science to understand um, psychological phenomena. So, in general, most of us as academics are, good evolutionists. We believe in evolution. We believe the brain evolved uh, primarily by natural selection. But if that's true, then that means that natural selection has really shaped the brain for its effects on behavior, psychology, emotion. And so evolutionary psychology is really about understanding or trying to elucidate, if you will, a lot about the evolutionary history of our thoughts, behaviors, and feelings. And one particular branch within that is like trying to understand the ancestral selection pressures that shaped how we think, feel, and behave. Um, and and so, and obviously there's this question about, people in modern environments. Can understanding anything about our evolutionary history have anything interesting to say about how we think, feel, and behave in modern environments? And the answer to that must be yes, because we only interact with our modern environments with the brains that evolution has given us.
Fair, fair. And I wonder if that's a part of the content of Civilization and its Discontents by Freud, where he says we are animals, we have all these urges, and he refers to it as instincts and id and pulses, and then we have to sort of we exchange that free life, that animal freedom, for the things that society brings to us, like safety, shelter, and some degree of stability. So we're not exposed to the elements and all the factors out there, but then we have to pay a price for living in a civilized way. Um, so I have to ask this, considering that most of our patients in the field come to us because of negative emotions
Mm-hmm.
that are somehow either sustained or very somehow impairing. Why do we have negative emotions from a evolutionary perspective?
Because they're absolutely crucial to survival and reproduction. Um, you know, it's kind of funny to me as an evolutionary psychologist to see a lot of, um, you know, uh, cultural dogma about negative feelings as if they're, we should be happy all the time. Um, if you think about the way the nervous system is designed, it's clear that evolution has given us the capacity to feel so many different kinds of painful feelings. And your psychiatrist viewers will certainly understand a lot about this. The whole nociception, right? There's so many different types of pain receptors uh, in the peripheral nervous system, and you have the capacity to feel painful cold, painful heat, crushing pain, cutting pain. Um, I think chemical burns, and maybe that's separate from electrical shock. I'm not really sure, but uh, you know, and then there's other kinds of painful feelings, like the pain of starvation, the pain of or distress of when you're sick. Um, then already I've covered a whole slew of different painful feelings. There's um, distressing or unpleasant tastes. You can have painful experience if the light is too bright, or if you hear sounds that are too loud. Um, there's and then we can cover what we might call emotional pain, which is getting closer to what your viewers will be primarily interested in. But even there, we have a whole slew, right? You've got fear and anxiety, all sorts of different kinds of specific fears or phobias. Um, you have anger, shame, guilt, regret, jealousy. You get it. There's a whole bunch that are there, and most of us would say, yeah, most of these are all quite normal, right? It's just when it comes to things like depression and anxiety that they there seems to be questions about, well, why should you ever feel depressed, or why should you ever have persistent anxiety, etc. I think that there's a time and a place for all of these feelings, and obviously I think today we're going to talk a lot about depression. But okay, so natural selection has given us all these different kinds of painful feelings. It's clear that they are there because of an evolutionary history, and most of us would understand intuitively why most of them are there. On the other hand, it's still there are still some frontiers, but nevertheless, you can classify all painful feelings as providing a similar kind of purpose or function. In biology, we call function. Oh, looks like you want to say something.
So you're comparing negative emotions with pain. So for example, the function of pain, obviously pain has a survival role, right? Physical pain, uh, it tells you something, that environment is hurting you. It tells you that you have to go about either protecting yourself, or moving towards a safer place, or fight an enemy, whatever. It's telling you something about your relationship with the environment. And what you're saying is that emotions do the same thing. So negative emotions will actually be sending you a message about your relationship with the environment, something that, in a sense, from a survival perspective, needs to be addressed, or is more complex than that?
Yeah, I think you have the right idea. Although I think we can be a little bit more specific than just there's something that needs to be addressed. I think painful feelings of whether it's you know physical pain or emotional pain, they exist to promote avoidant behavior and avoidant learning. what do I mean by those phrases? Well, avoidant behavior is trying to avoid something that will harm you further. So, for instance, when you have a sprained ankle, right? The pain of that motivates you to keep your weight off of your foot so that you can give your ankle a chance to heal. But it's also, you can put it in this avoidant language. You're trying to avoid, or your body is motivated to try to avoid damaging your ankle even further, right? Um, and um, so that's what I mean by avoidant behavior. You're trying to avoid some harmful event. And yes, when a predator is present, your fear would motivate you to engage in fight or flight, which is to avoid being eaten by the predator. Um, Jealousy is a pretty common emotion. The pain you experience or distress you experience when you uh, have jealousy motivates you to avoid taking motivates you to take action to avoid, you know, the consequences of your partner being unfaithful, whether it's an emotional infidelity or sexual infidelity, et cetera, et cetera. Okay, so and then avoidant learning is just another natural consequence of this. It's like, how do I avoid getting in a situation like this again? Right? Okay. And if you remember from your, university days and your intro psych class and all those experiments on classical conditioning and operant conditioning, they'd always involve something like exposing the animal to some harmful stimulus or painful stimulus like an electrical shock. And they're trying to explore how the animal learns in response to that. That's all premised on the idea that a fundamental aspect of that painful experience for the animal is to try to learn how to avoid that painful shock or whatever it is. So, yeah, go ahead.
Perfect. So since you mentioned conditioning experiments, I'm a psychologist as well.
Yeah.
I finished psychology before I went to medical school. But Skinner, I noticed that you give emotions a causal status, meaning you're saying, okay, emotions are causing this. Skinner would say otherwise. He would say the running and the fear are all the one same response, right? Do you care to develop on that thought that emotions are actually has this causative property for behavior as opposed to being the behavior itself? It's more a didactic separation. And I know this is an extra nerdish question, but I would appreciate an answer in that sense.
Yeah, it may also help to, elaborate on what we mean by emotion. Some people, when we talk about emotion, just in a layperson sense, would refer to, oh, it's just the feeling that I have, right? It's either the pleasurable feeling or the distressing feeling, and that's it. Um, uh, and they would separate it out from what the feeling motivates you to do. Um, uh, but within evolutionary psychology, there's maybe not a universally accepted perspective on this, but it is a widely adopted perspective, and actually, it's adopted by many emotions theorists anyway, or around, regardless of whether or not they're explicitly evolutionary, and that is that emotions or feelings are essentially coordinated whole body responses. So if you think about the problems that multicellular organisms like us have, we have all these integrated systems. We've got a cardiovascular system, a muscular skeletal system, a nervous system, et cetera, et cetera. And we go about our lives interacting with our environment. We encounter adaptive challenges, trying to find food, avoiding predators, finding mates, negotiating complex social relationships, et cetera, et cetera. And in order to respond to these adaptive challenges, actually our bodies have to respond in coordinated fashions, in many ways. In some sense, and one reason for this is because energy is limited. We can only devote energy to certain parts of our body at any one time. So when you're, Robert Sapolsky and his Why Do Zebras Don't Get Ulcers, Why Zebras Don't Get Ulcers, has a wonderful discussion about, when you are facing a potential predator, you need to activate your cardiovascular system and your musculoskeletal system. But you need to downregulate energy and devoted to, say, your immune system and your digestive system. And that's what I mean by a coordinated whole body response. Different parts of our bodies need to be differentially activated in response to adaptive challenges. And if you were facing another challenge, say, as we talked earlier, an infidelity, right, of a potential infidelity of your partner, that's going to require a very different set of coordinated system responses. And of course, when you have an infection, that's going to be a different set of ones. So how is it that these complex multicellular, multi-system organisms coordinate all of these different systems? This is what evolutionary psychologists say emotions do. They provide this coordinated function. So now, can we prove that it is causal, or versus is it just, something that happens out of the coordination is done in some other way? I don't know that it means a whole lot of, it makes a whole lot of difference for right now. We can at least say these feeling states are certainly associated with all these differential system activation patterns.
Perfect. And I think I understand what you mean. At the end of the day, the separation is didactic because the phenomena doesn't change a bit. Now, I like what you said about the zebras, because one question I have is, so we have emotions, and in a sense, I even though for so many years I was like a flaming behaviorist, I don't oppose the idea of a causal impact from emotions, because they seem to linger, and we seem to do things to get rid of them. In a sense, from a practical perspective, at least from a pragmatic perspective, they do work as such. But you mentioned the zebras, and we mentioned a few minutes before I mentioned the limitations of living in a civilized society, if we can call it. So I wonder if that we experience a persistence of negative emotions, given our circumstances, that zebras wouldn't. And I wonder if that persistence of negative emotions is what we would refer to as mood, as opposed to necessarily just emotions. Is there a duration component that gets us to feel or to experience illness stemming from emotions if compared to animals in natural environments?
Well, yeah, I've always been skeptical of the idea of moods as being sort of somehow different from emotions. Seems to me that one reason why emotional states persist is because we have the capacity to reflect on them. And in fact, we sometimes need to reflect on them. especially the human beings with their really, really complex social lives. Um, we don't just simply react to social situations because simple reaction, our social relationships are complex enough that simple reaction can just get you into big trouble. You often need to spend a lot of time reflecting on your complex social life to figure out what the best response to a situation is going or should be. And that may require you to reflect on things on this outside of the interaction itself. Like, you go to work, something happens, and rather than immediately react to it, you say, I better think about this. And you may think about it for a day or two or a week or sometimes even more before you end up deciding what it is you're going to do. That is that reflection that you engage in will affect your mood, right? And it's crucial to being able to do that. So, but you can still say that it's a response in some sense to your social environment. And okay, so that's one way in which you know an emotional state can persist for a long period of time, and we don't need to talk about it as if it's simply just a mood state that has no bearing on the situation that people are in. But another, and I guess it's sort of related to, this, the reason why we talk about this is with respect to, or one of the big reasons we do this is because of depression, right? Because depression can last for, days, weeks, months, years. Okay. Um, the, the way in which I still think, as I've gone through this, I think depression is an important emotion, despite the fact that it can last for months or years. But the question is why does it persist? We'll hold off on that, but because I think there's more things that we want to sort of set the stage for. But I'm aware of the question and the problem, and but I'm still going to say that this is really all part of a response to a complicated environment that like the situation I described with you. It's a complicated problem at work. You don't know how to respond to it immediately. You reflect on it. You need to think about it. We can still talk about that as a response to the environment.
And in fact, we are not just running away from our troubles. Is not. It's a funny thing, but running away from our troubles is just not doable for the most part, considering life in society. Now, so far we spoke about evolutionary psychology. We spoke about the potential role of emotions, and you made an analogy with pain, which is, I believe, it's a perfect analogy because in fact pain has a clear function. And then I have to, in talking about major depressive disorder and possibly generalized anxiety disorder, they're not, from a syndromic perspective, they're very similar, even though they may have different roles from a behavioral perspective or from an evolutionary perspective. But makes me question the word disorder or the claim that depression is a brain disease, considering the claim that it's actually performing a function, a survival function, or it did at some point in our evolution. Can you develop on that concept?
Which one? Which concept?
The claim that in major depressive syndrome would be a disease.
Yeah. Well, it is interesting that depression as a syndrome, it's a collection of symptoms then, as the DSM defines it, uh, that encompasses both, thoughts, feelings, and behaviors, right? And I will say that from the way a psychiatrist is trained to look at it, then it's they just call it a syndrome. But from it's equally possible to talk about it as an emotional state, simply on the fact that, again, all emotions, under the perspective I told you about earlier, will involve uh, coordinated systemic responses, which means inherently they will have effects on thoughts, feelings, and behaviors, right? Um, by affecting thoughts, feelings, and behaviors, it's clear that multiple systems are going to be involved there. So, but the idea, I mean, it is also true that even evolved emotions, if we're going to think about an evolved emotion as an adaptation meaning it is a trait that has been selected for over evolutionary time to perform some function, that they can malfunction as well. I mean, because if we talk about other traits like our eyes or our hearts or our kidneys or livers or lungs, um, pancreases and whatever, they can all malfunction at some rate, right? Okay. So, of course, I mean, this is just a property of, all all evolved systems, is that they work best during the reproductive years, but after the reproductive years, they start declining. And so we're all susceptible to having malfunctions in every organ system in our body. So while I'm proposing that depression is an evolved emotional adaptation, I would also have to inherently recognize that that can truly malfunction at some rate. Okay. So the concept I have to, and the concept that I'm going for, has to both figure out what does the adaptation look like when it's working well, and what does the adaptation look like when it's breaking down or malfunctioning. So to me, I know that what is and what is not a disorder is a hugely debated topic. But
I wish.
you wish it was
I wish
debated
it
more.
was. I wish it was at least debated, but that's okay.
Well, it's at least debated in the theoretical level. It may not be debated amongst the rank and file, but the so Robert Spitzer, he actually bought into the idea of Jerry Wakefield's harmful dysfunction um, definition of disorder, which is an evolutionary definition of disorder. And this definition proposes that all true instances of disorder involve have had there's two components to it. First of all, and I'm paraphrasing Jerry, but I think that it's in some sense a more easily understandable way of understanding it. That first of all, there has to be an adaptation in the body or the brain that is not operating the way it evolved to operate, and he calls that the dysfunction element of this. So you have to have a dysfunction. That dysfunction is an adaptation that normally performs a function, and by dysfunctioning, it's not functioning as well as it's supposed to function. Okay. Or the way it's evolved to function. So that's the dysfunction element. The other part is the harmful, and this requires some sort of societal or social judgment that this dysfunction is causing harm that is worthy of treatment. Okay, so the dysfunction part, he says, is objective. It is possible, it should be possible to objectively, scientifically identify all the adaptations in the body, figure out how they evolve to operate, figure out their functions, and then figure out essentially when and how they can dysfunction. The harmful component is subjective. It is not. It requires, some social consensus, but it's not the scientific part of his definition. Okay, so to me, the core piece of this is the dysfunction part. I mean, obviously, the social determination that something is harmful is important part. But as scientists, the one that we can really sink our teeth into is this dysfunction component. And I think it's the only really rational, credible definition of disorder that's out there. And yeah, go ahead.
No, let me see if I understood what the Wakefieldian understanding of dysfunction would be then. We have a trait or some degree of variability or a behavior or an emotion that is selected for the sake of helping us adapt to the environment, just like pain will make you avoid some noxious stimuli or something like that. For Wakefield, the disorder comes when that function doesn't attend its goals, or it comes when we have actually maybe what I would call an organ failure.
Okay, this is a statement or a question?
It's a question.
Yeah.
I'm not sure if I'm getting what Wakefield means about this disorder in that sense.
Yeah, well, okay, so let's take some easy cases. Okay. We know that the function, the heart, of course, is an evolved organ. Its function is to pump blood. And we know that, a myocardial infarction, I guess, represents a disorder because it interferes with the heart's ability to continue pumping blood. Okay? Yeah. Okay, so that's where you could recognize that as a dysfunction. Diabetes, type 2 diabetes, right? That we know that is a dysfunction. Where is the dysfunction? It is in the loss of pancreatic islet cells' ability to produce insulin, or at least that's one part of the dysfunction, right? Okay. So these are easy cases, right? The other part, we could say, obviously, somebody like me who has to wear glasses especially for reading, but that is you can have that there's a hardening of the lens there, right? That is, in some sense, it's not a complete loss of function, but it's a partial loss of function. And that's why the hardening of the lens would be a small dysfunction.
Perfect. No, I understand. So I got it. Yeah. So I think from a medical perspective, maybe we could call it. Maybe we would call it. We the doctors, as we could agree on things enough to make a statement. But we would call it an organ failure. There's a failure of that organ. And one struggle I have with depression is the assumption that being the brain, one of the functions of the brain obviously is to cope with reality, to relate to reality. I struggle with the concept that just that one piece, just the spread circuits related to low mood, so to speak, would be failing, as opposed to be instead a functional change in response to a persisting problem in the environment. I struggle to understand, and I don't doubt there is such a thing. I don't doubt there is a biological failure of the brain here and there, but even from a statistical perspective, organs don't fail too much.
No.
If you think about it, especially at the ages that we see them failing.
Yep.
In psychiatry, because because of pharmaceutical company advertising, so to speak, or financing of specific research and doctors, we have an expansion of diagnosis to children, and the assumption that the brain is failing exclusively for that specific function, the mood, as opposed to failing as a whole. What we call brain failures or encephalopathy. Maybe that's how we would refer to delirium, when the brain is really failing as a organ, and everything is messed up. Sleep cycle is messed up. Alertness is messed up. Reality testing is messed up. Attention is messed up. Memory is messed up. The whole organ fails. The idea that depression would imply a failure of one's, and we cannot even say a piece of the brain, because everything's so diffuse when it comes to the things that we do. All the functions are diffused through the brain, through different circuits, and it's kind of this crazy net that we still don't know how it works. It's hard for me to understand. Still, I think it's a possible thing. I just think that the frequency, the number of diagnoses of depression we see just cannot be attributed to a disease.
Right.
In that sense.
Yeah. I mean, there are lots of clues out there that depression, as it's diagnosed, is largely not a disease. It's or a dysfunction, right? Which I'm treating as essentially the same idea, even though some of your viewers might not agree with equating disease with dysfunction, etc. But the clues are depression certainly peaks during the reproductive years, and actually declines with age. And that's the opposite profile you'd expect from a true disorder in any other part of the body, right? That the rates of disorder increase with time and with age, right? Because we are eventually going to.
That's brilliant.
Yeah. Well,
that's brilliant. That's a brilliant view of it.
Yeah. It's not mine. I think Ed Hagen is my colleague, another evolutionary psychologist who studies depression. I think I heard him first mention that, and it's like, yeah, that is a brilliant idea. It's a great way of thinking about things. So, I mean, a lot of psychiatrists have expressed concerns that the DSM pathologizes normal emotional states, like Bob Spitzer and Alan Francis have certainly written about that. Jerry Wakefield has, and Tom Insel and Bruce Cuthbert, heads of the NIMH, also have those concerns as well. So the idea that the DSM is pathologizing normal emotional states is, these people aren't necessarily strong or deep involved in evolutionary theory or anything like that. They're just sort of saying, look, the numbers are just too common for this to be a true disorder. And by the way, let's mention the in addition to the age profile, the absolute numbers are astounding. I especially in longitudinal studies, where you assess people multiple times in their lives uh, and aggregate what they say. You take the rates of depression or lifetime depression when you aggregate the answers over longitudinal studies are close often to 50%. I mean, how is and and at least there's a few studies. I think I can't remember where it's from, but that where they do it longitudinally in young adolescence to young adulthood, and there it's in the 50% range. So they haven't even lived their whole lives, but the lifetime rate of depression up to that point is 50%. Okay, right? I mean, it's just, I think that another way in which I think about it is, look, most of us have at some point had somebody break up with us that we cared about. And if that happened to you, most likely you got depressed for a couple of weeks at the very least, right? And people forget about those experiences in their lives, but you know, those usually involve quite a bit of heartbreak, and uh, when that happens, most of us would have probably met the DSM criteria for major depression. I would say.
Absolutely. And so then let's go back to this, to understanding depression from an evolutionary perspective, or as a functional response to the environment. And functional, not only from a behaviorist perspective, functional in the sense that this plays a role, and it's a natural reaction to life events. And you have in one of your papers covered the inescapable shock studies, and you also made you before that, actually, or actually related to that, you you showed two analogies to depression when you talk about the whole major depressive syndrome. One is response to inflammation, and the other one is response to starvation.
Hmm.
And I think response to starvation was the one that kind of better fits the changes that we see in the syndrome, in the depressive syndrome. Do you mind explaining that to us?
Yeah, well, so I mean, I've been thinking about depression for a long time, but was trying to think of, just as the clinical state, the ruminative type and everything. But, uh, and I'm not a physician by training. I told you what my background is. It's like, but I eventually in my reading just came across descriptions of, you know, I think the first one that I came across was sickness behavior is a type of depression, right? When you get sick with an infection, you're technically you get the sad or low mood. You lose your ability to feel pleasure, so you get the anhedonia. Then, of course, you've got other symptoms that are part of the depressed state, they. But what makes it depressive is the low mood and the anhedonia, and that also happens when you get when you know when people experience starvation. And you get a bunch of other symptoms that differ from, say, sickness, depression. Anyway, I became very interested in like this, and I started thinking about um, the relationship between these things, and why are they depressive? And one of the things that was very interesting to me is that both sickness and starvation are energetically stressful situations. Um, in obviously, when you're starving, you don't have enough food coming in, and your body is forced to metabolize itself to keep itself going. Okay. Um, uh, And there are necessarily trade-offs that have to be made in starvation then, right? You have to keep the brain going first and foremost. One of the impressive facts about starvation is that even the heart loses muscle mass under starvation. That is, and that's how important it is to keep the brain going, that even the heart gets sacrificed. Obviously, it can't be fully sacrificed, but, nevertheless, that's still an impressive fact. With sickness and infection, we all, you probably remember, with fever, your metabolism goes up. Like for every 1 degree centigrade, it goes up 10 to 12%. So a 2 centigrade fever will, increase your metabolism almost 20 to 25%. Usually during sickness, you have a loss of appetite. Why do you lose appetite? Well, you're trying to mobilize your immune system to fight off the infection. So there's a lot of proliferation of antibodies and activation of innate immune cells. All of that is massively energetically expensive. And in modern environments, we might say, well, why do we eat less? If you have this major metabolic demand going on, then why shouldn't you just eat more? Well, we didn't evolve with refrigerators and cupboards. If you in an ancestral environment and you're sick within an infection, going out and hunting and foraging for your food will require you to expend massive amounts of energy that can then not be used to fight off the infection. So you have fundamental trade-offs, energetic trade-offs in sickness and starvation. Some systems in the body, like in sickness, you activate your immune system, but you downregulate digestion, reproduction, maintenance. You tend to be lethargic, so you're reducing your physical activity. You can't think as well, so your brain is, even that, you're sort of reducing some of the expenditure of energy that would take place in your brain. All of that's done to fuel the immune response. In starvation, you have another set of trade-offs. You got to keep the brain going, but you actually have to find food. So surprisingly, during starvation, you actually have an increase in physical activity, but it makes sense if you understand that in starving animals will migrate as long distances to try to find food. That's, they have to do that. Okay. So depression is involved in these states. They're massively energetically stressful states. What is the relationship between that? And I started seeing that the symptoms of depression in these two states were actually facilitating the energetic trade-offs that the organism is having to make. That let's take the sickness depression. You lose your interest in sex and humor and food. But if you were interested in those things, you would be spending energy and effort on sex and social companionship and foraging that would then not be spent on your immune system. So that's how some of the symptoms within sickness depression particularly reflect an altered motivational state. So the anhedonia that exists within sickness depression is it's not blanket loss of interest across the board. There's an interest in sleeping, and also it's an anhedonic. When you lose your interest in food, there's still there's an alteration in your food preferences. When you do eat, you tend to prefer carbohydrates when you're sick. And that, of course, is classic sickness, that's classic food that feeds your immune system. So also there's a loss of interest in iron-rich foods. You don't want to eat a big juicy steak when you are sick with an infection. And that's a functional change as well, because iron is a limiting resource for pathogens. The more iron you have circulating in your blood, the better the pathogens do. So there's rather than thinking about anhedonia as a loss of interest, it's an altered motivational state. And the same thing happens in a different way in starvation. There's a loss of interest in sex and humor and social companionship. Those are common, but there's an increased interest in food. That's different than the sickness state, right? Okay. And so you see how the anhedonia is it's being modulated in these two states. And I think that is an important fact that is not well appreciated by anybody in the mental health fields. I mean, when we think of anhedonia, we think of, oh yeah, it's just anhedonia. You lose interest in everything. No, that's not right. You retain some interests. And if you understand the pattern, it helps you understand what the adaptive challenge that the organism is facing. Take this all back to ruminative depression, the one that we care more about, right, from a clinical perspective. Well, what does the pattern, energy pattern look like? Remember, I'm now assuming, I'm going to take the principles that I've learned from studying sickness and starvation and apply it to rumination. I don't know exactly what the adaptive challenge is, but I do know that if I can understand how the body is allocating energy, and if I can understand how anhedonia is being selectively altered, I might be able to make some inferences about the adaptive challenge. Okay? And what do we know about ruminative depression or melancholic depression? Well, there is a fundamental energy reallocation that is going on there. It was noted by Freud in Mourning and Melancholia that there is a lot of energy being spent thinking, right? And the person may be sitting at or lying on his bed or sitting at a chair and being very static or whatever, but that is concealing the fact that massive amounts of energy are being spent in the brain. And you even have, go ahead.
Frequently guilt.
Guilt, worthlessness. Yep. We'll get to that.
Yes. Please, then just please continue.
Okay. So we know that the body's energy is being reallocated. And by the way, cortisol is going, right? So you've got cortisol mobilizing energy in the body. You have insulin resistance developing in the peripheral tissues. Where is the energy? So energy is being mobilized, but it's not being used by the periphery. It's all being sent up to the brain to support rumination. Okay, what about the anhedonia? Well, we commonly say these depressed individuals that have lost interest in sex and food and social companionship and yucking it up with funny jokes. What is it that they have any preferred interests? Well, yes, they do. There is a lot of literature that says that people find their ruminations valuable. Now, clinicians dismiss this. A lot of them, sorry, I don't mean to say all of them, but a lot of clinicians dismiss that because they believe, they've been taught that the ruminations that depressed people have are actually counterproductive. Well, fine, but let's at least acknowledge that this preference or this belief reflects an interest. They They do believe that their ruminations are helpful. They also have treatment preferences, which also, I think, reflect something about the preservation of certain kinds of interests. We know that despite decades of uh, attempts to try and get people to think and believe that antidepressants are safe and effective, that most people, when they want a treatment for depression, want to talk to somebody. And the more problems that they have, the more they ruminate, and the more they believe that, the more they want to have a psychotherapist or somebody that they can talk to. So, um, so these reflect a preservation of things that are of interest, or that are and that are desirable or that people want. When people are depressed, even though it's a painful state, they want to think, and they want to, ruminate. Secondly, they want to get somebody else to help them think through their problems with them. Okay, so this is telling me that probably there is a complex problem in people's lives that they are trying to think through, and that is the fundamental adaptive challenge that's at stake with ruminative depression.
So I would say you refer to that as reverse engineering in one of your papers, and I want to say that I would refer, I would describe it as incredible precision, but let's try to be humble and say there's a reasonable amount of precision in that reverse engineering. So my next question will be how the problems we face nowadays, societal, relationships, professional, whatever things, would lead, from an evolutionary perspective, to a response that is equivalent to the response to starvation. Because we really don't have, some concrete thinkers may say, well, we don't have any problems to find food. And for the most part, it's true. From a survival perspective, maybe I would say the world was never as safe as it is today. We have lower murder rates. We have less starvation today than probably ever before in the history of humanity. We can question this thing because we have less murders, but nobody's getting out of their houses, which makes life very boring in a sense. But that's not the point. The point is to say, from a survival perspective, we are at a all-time high. We live longer and better. Why would our problems, why from an evolutionary perspective would we borrow that set of responses or physiological changes from starvation to help us cope with the problems we have nowadays? Does it have to do with social exclusion and the meaning it had back in the day? How do we make that bridge?
Yeah, it's a great question, Rod. So survival isn't the only thing that natural selection cares about, right? If you can allow me to use that phrase as if natural selection has agency. It doesn't, obviously. It's just a phrase. The the basic ideas in natural selection is it's differential reproduction and differential survivorship. So, you know, by the way, the United States isn't doing so great on a lot of these metrics as you might, you know, as many other Western societies, right? There's been a degradation in, relative to other countries in Western societies in the United States. But what is that about? There's wealth inequality. There's differences in the quality of education. There certainly are. Um, you know, isn't there? You might know this better than I. isn't mortality for what is it, during childbirth or infant mortality is also increasing in certain populations within the United States. I'm sure some of your viewers would know some of those statistics better than I. But the thing is that organisms, whether it's human beings or gazelles or chimpanzees or ferrets, whatever the organism, there is competition within every species for um, survival, but most particularly reproduction. And just because the survival part is pretty darn good in Western societies doesn't mean that we've given up on the competition for reproduction. And even though we're not, consciously competing for reproduction, and in fact, many people choose not to reproduce, what we do compete for, what we've evolved to compete for, are for resources that are useful for reproduction. Things, obviously, like in a modern context, we would say things like money and status and reputation, right? Education is something that we can compete for too, because that education affects all sorts of opportunities, right? So we haven't given up on, humans haven't given up on the competition. We're incredibly competitive. Okay. Now, also in modern Western societies, there's not a lot of physical violence. I mean, there is a lot of, in the news, there's certainly a good amount of physical violence going on, and I'm not trying to dismiss that. But what I'm talking about is we don't tend to generally compete by using physical violence. A lot of our competition is actually cognitive. We use our brains to try and outcompete other people, and um, you know, and I just appeal to your viewers to just think about your own work environments and how you try and give your kids an advantage over other kids, and trying to get them into better schools and everything like that. There's a lot of cognitive thought that's involved in how we try to compete in Western societies. Okay, so that's because our social environments are so complicated. And part of the complication is that we can get punished for using physical violence to compete. So we have to rely on other more sophisticated intellectual cognitive ways to compete. Have I answered your question?
I believe so. But yes, and so if I can summarize, because um, um, I always thought when I saw the bridge you made between either inflammation or, and specifically, more particularly, starvation, and thinking that many of the struggles we have that we see in clinical work uh, uh, are related to, and I like the way you put it because it's opening my mind actually, the competition itself, the having the resources, social differences. We're not really facing starvation for the most part, but all those other things are, and there's a fair degree of I'll use a specific example here. So we have Social Security benefits in the United States, right? Mm-hmm. Which pretty much are, as a financial aid, it keeps you in your couch. It's slightly below the bare minimum to live life, so even your mobility is impaired. If God forbid you have a car, you don't get it. But if you get it, your ability to go places, it's severely hampered because you cannot just walk around. You got to have some sort of transportation, and that frequently leads to a fair degree of isolation, and in a sense stagnation. people are not chasing anything anymore. They're just sitting there, and it's really enough to have some very boring food, or caloric intake, if you will, and possibly keep you paying Netflix, and you sit in front of the TV, and that's it. That's it. And obviously, a huge amount of people on disability are getting depressed as opposed to being on disability because they were feeling depressed, which is kind of a case of death. But my thought was, okay, why would they start behaving as if they were starving? Now, my first thought is we are designed, or evolution selected the a few other emotional needs that we have. But I thought that was too superficial, and I said, okay, I'm not thinking this thing right. Does isolation lead to depression, or do social, what I mean is, like, let's say a conflict at work, or being left by someone you love, or things like that, does that lead to a pattern of behavior that equals starvation? Because from an evolutionary perspective, that means isolation. And because it means isolation, it really, not a lot of primates live alone in nature. We are social animals for the sake of survival. That was the bridge I was looking for, or the answer I was looking for, in the sense of, why do the problems that make us feel down nowadays would make us behave as if we were starving?
So, yeah, I mean, there's the equation of ruminative depression with starvation. I would say that ruminative depression borrows some features from starvation depression and other features from sickness depression. For instance, there's the sickness depression and melancholic or ruminative depression both involve a loss of interest in food, right? Which is different than in starvation depression, where there's an increased interest in food. It's the thing that makes, I think you're honing in on, is when you're starving, you actually, all your cognitive thoughts are really directed towards, they're obsessed with finding food. And so it looks like the starvation may have involved some of the origins of rumination, right?
I get it now.
Possibly, right?
I get it now. So the rumination is actually, okay, there's a problem and we're just really trying to solve it.
Yeah, yeah. So yeah, I would say that the starvation, there is this problem of finding food, and that will require you to apply your brain as well as to, physically, move around and to find food. So there's an increased physical activity. Yeah, and then the 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 problem is, in human social lives are so complex. And you're right that we are inherently group living because we're interdependent upon each other, and social exclusion can be a huge threat then to an individual in humans. Um, but the problems are so complex that we need to sometimes expend massive amounts of intellectual energy towards trying to solve those complex social problems. That requires fundamental energy reallocation, in which the energy has to be devoted to the brain to support that intense thinking to solve those complex social problems. And then other systems in the body will have to be downregulated. like reproduction, digestion, physical activity, um, even sleeping less. I mean, there's that classic symptom of melancholia, of early morning awakening, and and we know that that greater amounts of rumination are associated with less sleep. Um, so there's that energy allocation thing. So I mean, I think so. Part of it is just simply the human organism, when facing a really complicated social problem that may be putting them at risk of social exclusion, will it's worth it, to expend massive amounts of energy to try to solve that problem and avoid the social exclusion. It's worth it so much that at times you will need to become depressed and, you know, spend all most of your time on just trying to think your way out of this problem, even at the expense of physical activity, hunting and foraging, um, et cetera, et cetera.
Okay, okay, I get it now. Yeah, I was making this kind of a direct bridge without entertaining the expansion, let's say, of the. Now I see what I see where my mistake was when I was thinking about this problem. Now, before we move to talk a little bit about antidepressants and the role they would have in this process, I mentioned something about guilt
Yes.
when we're talking about. Do you have any thoughts about that specifically in terms of its function or its role in major depressive syndromes?
Yeah. Well, we didn't really talk it. You know, I think there's more that we can talk about with the function of depression here. Um, the we're still trying to figure out um, if our proposed explanation can help us understand the symptoms of depression as the DSM, and the melancholic type would be associated with uh, thoughts of worthlessness and guilt, as you pointed out. There's the difficulty concentrating, um, et cetera, et cetera. Um, yeah, I I like to say that when we're talking about the function of depression, I have I have told you what I think the energy allocation problem is. There's some complex problem, um, but I've also told you that all painful feelings have an avoidant behavior, avoidant learning function. So, what is it that the depressed person is trying to avoid? We could say it's social exclusion. Um, and social exclusion is certainly an important trigger, but we're also familiar with characterizing depression as a response to loss or failure, right? And I came across this fascinating literature um, that helped really put things into clarify things for me. And it's this literature that I'm sure you're at least somewhat aware of, because it's physicians' own emotional responses to making serious medical error. Okay, and so I think this is such an important literature, and it will help your viewers really understand the idea. Okay. And almost, medical errors they are just an inherent part of medicine because we're human beings. And even though physicians have really good brains, we're all just subject to making errors at some point in our lives. Andy Thompson, my longest psychiatrist friend, tells me, yeah, every physician is going to make a serious error at least once in their lives. And that error can have a negative impact on the patient. It might kill the patient, you know. Um, we're talking about pretty serious stuff here. Now, but they often, errors are probably more common during training, right? The early years. So what I'm going to lead you through, as what I think everybody in your audience will intuitively understand, is the emotional response of a physician who's made a medical error. And I'll help you to see how the symptoms of ruminative depression are useful in this context. Okay, so let's just imagine a physician has made a serious medical error. What is their likely emotional response to be? Well, first of all, they're worried about all sorts of things. First, they've hurt their patient. That's not why they got into this business. They're not there to hurt patients. So this is a hugely distressing thing. Secondly, there are concerns potentially about loss of reputation, how their colleagues will view them, possibility of a lawsuit, possibility of losing their medical license. These are all huge, serious threats to the person who's made a medical error. So is it understandable that they would have a serious emotional response to this? Absolutely. And what are the emotional responses? Depression, anxiety, acute trauma reaction. And they commonly reach clinical levels. Okay, so there's this whole literature on this. The second thing that we know is that the physician commonly takes corrective action. That they try to reduce their chances of making a similar mistake in the future. They're trying to avoid making a similar mistake in the future. And how do they do that? Well, the literature says that they do things like, read up on the medical literature that surrounding the error. They'll document in the chart more carefully. They'll read the chart more carefully. They'll seek out respected advice from senior colleagues when if they feel like it. At the same time, they're more likely to personally double check information. So these are the kinds of measures that they're doing. Okay, but the details may differ on precisely what happened. The second thing that we know is that the degree of angst that they feel is positively correlated with these corrective changes that they're making. This is crucial, that the angst that they feel is motivating them to make these corrective changes. And this implies, and it goes up to the clinical level. Physicians who've made a medical error that makes them feel so bad that they themselves seek out therapy are the ones who are the most likely to make corrective changes. That's a crucial, important part, because over the decades in which I've been doing this, sometimes my clinical colleagues will tell me, Dr. Andrews, your theories about rumination are all very nice, but they don't explain my patients who I see, and they often have tried to differentiate help-seeking patients from those as particularly evidence of some sort of disorder or something like that. But here we're seeing that even at the highest clinical level, their help-seeking is associated with greater corrective changes. Okay, and we would all agree that in medicine, since mistakes happen, that it's crucial that people learn from their mistakes. You can't get rid of mistakes, but you want them to learn from their mistakes. So that angst is crucial for this to happen. Okay, and the corollary to this is that a physician who makes a mistake but doesn't feel any angst is not likely to be making any corrective changes. Okay. And there's, several independent researchers have noticed in this area that for that painful feelings are useful in helping young physicians learn from their mistakes, and that an attempt to soothe and and help the young physicians not feel the pain could potentially be counterproductive. Yeah, there's an anecdote of and if you'll allow me to do this, I'll just describe this anecdote to you. It's in the published literature. It's I guess the British equivalent of a resident who is being interviewed by one of these researchers, and the researcher asks the I think it's a male, I don't know for sure, if he's ever made a mistake. And he goes, "Oh yeah. I've made some mistakes. There was this one guy who I didn't check the blood work, and he kind of passed on. And then there's this other guy who I didn't was tanking, and I didn't call supervisors fast enough, and he went and passed on. And there's a third one that I can't remember the details about, but yeah, he passed on." And there's the tone, and it's just in the written record, but even the writing, the tone that's expressed by the writing is sort of stunning, because this resident is essentially not really, he's almost casually saying it. In fact, he goes on and says, yeah, you could say that I made these mistakes and blah, blah, blah. But you know what? I'm just a resident, and I'm supposed to be supervised. So you could almost blame it's my supervisor's fault that these patients died. I mean, that was just like, whoa. Okay. So at the end of this article, the researcher basically says, the current emphasis on reassurance and amongst trying to reassure young physicians who've made mistakes can be counterproductive. We want, people to learn from their mistakes, and no sense of angst, no sense of responsibility, no sense of, whatever regret. That may actually interfere with learning opportunities. Okay, so now I think you've got a really good idea. Now we can just talk about the symptoms that a physician will have and the role that they play. A sense of guilt or self-blame, well, in the context of having made a mistake, that's actually pretty functional, right? Okay. But it's also functional. It has a broader context too. We can extrapolate this principle to beyond a medical error, and we just say, look, if you've experienced some harmful event and you want to reduce your chances of experiencing it again, you need to think about what role you may have played in that harmful event so that you can figure out what you can do in the future to avoid something similar. Self-blame is functional. Okay. What about worthlessness or low self-esteem? Well, if we go back to this British resident, he seems to have a pretty good sense of self-esteem. Maybe that's not so functional in this case, right?
Yes, that's brilliant. That's absolutely brilliant. Yeah.
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 And then we can talk about pessimism. If you think, oh yeah, I had this bad thing happen, but it's never going to happen again, that's not pessimistic, right? Well, what's the point in changing then? Right? You kind of need to think that the future is going to hold the possibility of another mistake or another loss or another failure in order to take corrective action and maybe avoid it. There's this concept called defensive pessimism, you may remember, since you've got that psychological background, that's really useful for this kind of thing. In fact, the fact that depressed people are often unduly pessimistic, meaning they think that their futures are worse than they actually end up being. Well, that actually may be proof that they're taking corrective action that makes their future end up being better than they had predicted. Hence, it's useful as well. Okay, I think I've given you now a pretty good understanding of how the symptoms of ruminative melancholic depression are really work within this avoidant learning framework.
Perfect. And it's recently I interviewed Marjorie Gounod. She's a developmental psychologist, and she researched a few topics, including time out for children and spanking and things like that. And one of her positions is that the folks that oppose her, they are in favor of something called positive parenting, exclusive positive parenting, which is and it seems to be motivated by this effort to prevent negative emotions in children. And we spoke extensively about it and how ideology is actually influencing science as opposed to the other way around. And I think the things you're saying are so meaningful, because it seems that the focus of mental health professionals nowadays has been to change emotions as opposed to help people change their circumstances, or the learning, or in tolerating negative emotions. Really, we know that the ability to do so varies significantly between individuals. Maybe from a DSM perspective, the patients that struggle the most with it will be the ones that will meet criteria for personality disorders. Have and in fact live so erratically as to be able to get rid of negative emotions through very impulsive actions, and that is indeed part of the trouble. It is the fact that we can't sit, that population, let's say people that meet criteria for those personality disorders, they struggle more than your let's say average person to tolerate negative emotions and sit with it. And the other funny thing I find in psychiatry is that despite the effort all directed towards suppressing negative emotions with drugs or therapy or self-talk or whatever, is that we just patched the concept of mindfulness on top of it. Like it's not in an organic way. We just said, all right, and there's this. As we try to get rid of our emotions, all the messages try to get rid of negative emotions. The whole PHQ-9, GAD-7, assessment tools, everything, medication tweaks, everything is designed to get rid of negative emotions, as if it was like a big no-no. And on top of that, we patch the concept of mindfulness, and we continue to walk and make this business run as usual. Which leads me to the antidepressant, and I you mentioned the possibility, and you mentioned some studies in your papers where antidepressants could in fact be hampering. In any sense, I'm looking for a patient's lives. Do you care to develop a little bit about that before we end?
Yeah. By the way, I'm happy to be with you again sometime, Rod, if this is useful to you.
It would. Oh yes. Thank you thank you for that.
No, this is fun. I'm enjoying it. So, yeah, I mean, the goal of the antidepressant medication has always been to, as you said, reduce or suppress the symptoms of of depression, if we think about those symptoms as actually being facilitating this avoidant learning function, right? Then antidepressants, to the degree they're effective at reducing symptoms, should therefore interfere with the avoidant learning function. Should interfere with the ability of the individual to do the avoidant learning. And if they're, in this case, you could imagine take our physician again who's made a medical error and is feeling miserable about it. And if the first thing that happens is that the physician goes and seeks out treatment and gets an antidepressant, well, it may be then that the physician is going to be less likely to learn from that error, right? So one of the things that I'm particularly interested in, searching through the literature for is because I'm not a physician. I don't do research on antidepressants, in my lab, for instance. I don't treat people with antidepressants, but I am interested in evidence that antidepressants do interfere with avoidant learning, and there are not many studies on this. There's a 2013 paper by a psychiatrist whose last name is Herzala that looked at depressed patients. Some of them, I think, were some of them were medicated, some of them were unmedicated, and then there was also a healthy control group as well. And he put them through a cognitive task that involved, some kind of, I guess, it involved learning either in response to positive feedback or negative feedback. What he ended up showing is that, oh yeah, and the medicated were on, I think, SSRIs or something like that. So, in response to positive feedback, the medicated and the healthy controls were very similar. Okay. And that the depressed but unmedicated were not particularly responsive, were not as responsive to positive feedback. Okay, well, that kind of makes some sense now that we've understood some things. But what about negative feedback? Well, the unmedicated depressed patients and the healthy controls were more similar, but the medicated depressed patients exhibited worse patterns. Okay, which showed then that there was this, the medication seemed to interfere with the ability to process this negative feedback and promote and interfered with the ability to learn on this cognitive task. And then they sort of looked at essentially a ratio of the response to negative feedback versus positive feedback. And there the difference was very clear how the depressed patients sort of stood out. The unmedicated depressed patient stood out. So that to me is like the best behavioral study that I've seen on this point. But I think it's a crucial issue that people should be researching. And, yeah.
There is a lot about, yeah. I think one concern that a lot of people have, I would say, in the critical psychiatry movement, myself, maybe Robert Whittaker wrote about the possibility that antidepressants are in fact hampering change.
Yeah.
And from a psychotherapeutic perspective, from a philosophical perspective, even from a romantic perspective, because a lot of psychotherapy, because it's an art, you have to be able to tap into things like, even though if we fail to explain these concepts from a psychological or scientific perspective, we have to tap into concepts like inspiring things. You have to be inspired. The procedures, the process of psychotherapy has to be inspiring and motivating enough to get people to change their circumstances for as long as, except of course over the past decades where this psychiatric model saying that depression comes from the brain as opposed to say depression comes from the relationship between the brain and life and reality. We have to tap into openness to change. We have to tap into things that can actually foster movement and oppose stagnation. And one concern there is do medications are fostering stagnation? Are we trying to eliminate negative emotions so people stay exactly where they are? Are antidepressants stay put medications as opposed to keep moving medications? And it seems that just like in, and we don't have data on that, you're absolutely right, but just like in an analogy that I use is that delivery, if you do anesthesia too early in the process of delivery, it arrests the dilation and contractions. But if you do at the right moment, in actuality, you actually foster contractions and dilation because now the fear of the pain is no longer there, and the whole process is already on the go. A lot of people have different similar thoughts in that regard, that we could be using medications in a more strategic way to help people get over the circumstances that are holding them back. There was recently a paper by Langley which caught my attention because one of the authors is sponsored by pharma, saying that I think it was citalopram impaired consequence-based learning, even though like normative cognitive tests are not impacted by SSRIs, maybe with the exception of paroxetine because of sedating effects by anticholinergic properties, but impairs consequence-based learning. And at the end, they actually write that may account for the numbing impact that SSRIs are said to have. And now, for more than 20 years, people have been saying that SSRIs have emotional numbing effects, as opposed to be antidepressants, that they cut both top and bottom of the emotional amplitude. And it really got me suspicious because there was a doctor who had some ties with pharma among the authors, and I was like, what's coming? What's coming? And there's a history in the field of psychiatry that every time you ran out of patents over a given class of medications, you start dissing it to favor a new class of medications that is still patented. Another paper, there's a big paper, all by most authors are also related to pharma, talking about mortality of antipsychotics. The data is good. The motivation is what gets me suspicious.
Right.
But Paul, let me tell you, this was a very cool conversation. I really appreciate you offering to be here again, because most likely I will reach you again. And as soon as, and again, thank you very much. It was a pleasure to have you.
Thank you very much for having me on your program, Rod. It was a lot of fun.